The table 2 we're looking at, do managers have the right professional ethos and status? What could be done to address the situation?
Perhaps question 2 answers question 1 really, in terms of what can be done. We had a discussion like you did about what the sort of words around ethos and status, and we thought that status doesn't help. It's about standing, about public standing rather than status and hierarchy.
What's the difference between those two words, do you think?
I mean, when we were debating, it was something about hierarchy. Status was much more about position, and hierarchy, standing, was about reputation, collective reputation. We also mentioned that the problem with the idea of ethos and different professional ethoses is we do have many professions, and perhaps what we need to be thinking about is a public service ethos that unites everybody right across the service. We also talked about a community of management and the need for, or thinking about where are the hero leaders in the NHS who can be looked up to and look to lead things forward. We talked a lot about celebration of what we do well, and then we talked about collective reputation and the notion of stewardship in this public service ethos and the standing that we want to create with the public. And the creation and the sort of living creation of a collective endeavour, a common endeavour that we're all trying to work towards. We talked a lot about the media and the impact of the media on the standing of NHS managers. And we talked about the complexity of the decision making that managers have to come to, about doing the difficult things, and perhaps if I pass on to you about currency.
I think what I was trying to say was that when you do the difficult things, sometimes with clinical colleagues alongside you, the manager is the focus of attention of local people in opposition, and you use up an awful lot of currency when you do that one thing. Mm-hmm. It makes it very difficult for you then to go on to lead the organisation into the future.
Absolutely does. And we witnessed some of the debates that people have experienced around reconfigurations and managers having to take those lines. This public service code of conduct that you've been talking about, is that similar to the idea that Judith raised that they've had in New Zealand? Is that a model that sounded of interest to you?
We didn't get that level of detail really. We were just raising the issue about commonality, rather than something that could be quite divisive.
Something that, recognising that managers come from lots of different professional backgrounds, it's not appropriate to differentiate out one set that come from a sort of an administration background, from a medical or clinical background.
And I think our final point resonated with yours, which was about personal resilience of NHS managers and the importance of that to stand in and stewardship and the ability to do the job.
Yes. And in fact, that it does touch on the points that the group over there were making around, well, we don't have a huge number of people now coming forward to these chief executive and senior posts in particular, which suggests that there might be a bit of a problem. What other comments on this question that people might have?
Just picking up on the point there about this code of conduct, the NHS constitution that was put in actually has a code there, and we were putting in a professional code of conduct and working for our clinicians, but we put that on hold on the basis that we use the NHS constitution. So maybe there's something around picking that up again.
And augmenting it perhaps.
Yes, yeah.
We talked during the day about the manager's code of conduct. Do people think that there is that it still has some mileage? It's 10 years old. Is it still valid?
Can I ask you a question? Could I ask anyone who has looked at that code of conduct in the last 5 years to put their hands up?
Oh, you're surprised at the...
Yes, I am.
What are your comments on that? Do you think it's still got currency in today's NHS? Does it need to be still used, or does it need to be changed?
I looked at it about 2 weeks ago, and I was quite surprised how relevant it still is, and it's got a focus in relation to patient care. The problem is, like a number of these things, it hasn't been properly implemented. So it just became an initiative, and it's not, I don't think it's routine. I know it was mentioned in the case study this morning that it was part of contracts of employment. I would think that's very lone organisation, and I think it is something that perhaps we could focus in relation to contracts of employment, feature in appraisals. It's never featured in any feedback to me in relation to appraisals, so it's got to be meaningful in terms of implementation.
But I guess that, you know, if something still looks relevant after 10 years in the NHS, given how many reorganisations we've probably had over that time, it's probably pitched at about the right level. The comments?
And you've used it. Did you have to change it in any way?
I mean, the NHS Code of Conduct is very much a set of guiding principles that just have just as much relevance today as they did 10 years ago. They are not sufficient alone to tie them into your contract of employment with our experience. We had to write a much more detailed piece of work that was around the behaviours that underpin the code. So there is more work to be done. Just reinventing the code won't help.
You have to localise it to what you're expecting in your organisation, so it's got teeth, in other words.
I'm an observer from the committee, as it were. Just a historical word about the NHS Code of Conduct. When the NHS Code of Conduct was introduced, I was chairman of a thing called the Academy of Medical Royal Colleges, and Nigel Crisp was the chief executive. And there was quite a lot of pressure from behind the scenes, from doctors' organisations, particularly the colleges, that there should be something equivalent to the duties of a doctor, which should apply to managers. And that was the starting point for those discussions. They were then taken forward by Nigel and his team, and they were distributed around a relatively limited number of doctors' organisations, and then published as a code of conduct for NHS managers. But the general idea was that they should form a comparator document to the duties of a doctor as issued by the GMC, which at the time were then relatively new. And I think from that point of view, they were a success. And for me personally, it's a disappointment that they haven't had a wider exposure and become more relevant to, as Caroline has said, the annual appraisal of managers and how they self-measure up against that particular format, which then makes doctors and managers very similar. It went hand in hand, sorry to go on about this, but I think it's important. It went hand in hand with a document which was produced by the GMC called Doctors in Management. And I cannot remember the exact wording, but I'll paraphrase the key sentence in it, which said that when doctors were responsible for populations of patients, they should make decisions which were the benefit of the group of patients they were talking about. But when they were personally responsible for the clinical management of a patient, they should make that patient's management their main responsibility. And that document was issued around about the same time, and it was meant to get over the problem of doctors stepping out of a one-to-one relationship with patients, which often resulted in shroud waving, into a mindset which looked at the most cost-effective delivery of service across a variety of clinical areas in a particular health economy.
Thank you.
Thank you.
It's
Sorry about
interesting.
that.
No, it's interesting to know where it came from, and that you mentioned the duties of a doctor. It's something that I think we're going to come back to in our seminar on culture next week, but I'm struck by how relevant the way that those duties are worded to NHS staff generally, not just to doctors. Okay, yeah.
Just as an interest, along with the code, there was a useful paper on implementing the code, in particular what happens when you breach the code. And I think that was partly due to the good discussion taking place at the time. There was a statutory instrument that went with it, and it was interesting that in the final sentence of the statutory instrument it says the fact of compliance or non-compliance with Direction 2 shall in itself have no effect on the validity or enforceability of a contract entered into by an NHS body to which these directions apply. That's still the law. So that would need to change.
Absolutely. Thank you for that. Gosh, we're getting a good history and a legal lessons here.